our Pedicardio e-teaching program. So we're happy to have you here. This is the first class for you, and it's 2020. So welcome you, and over to you, doctor.
All right. Thank you. Thank you for this opportunity, and I'm very happy to participate in this e-class session. And I'm sure everybody can hear me. And if you have any questions, you can stop me in between and ask questions. But here we can here with closure. Um, and just a brief introduction about me. I'm Manish Bansal. I'm a pediatric intervention cardiologist at Texas Children's Hospital in Houston. I did some of my initial training at Narayana Hirudayana in Bangalore with Dr. Maheshwari, and that's how I know her very well. Um, so the educational objectives for today's class would be and we'll briefly discuss the anatomy and physiology of ASDs. We'll discuss the indications for ASD closures. We'll discuss the procedure of ASD closure and the complications associated with transcatheter ASD closure. Since I'm a pediatric interventional cardiologist, I'll be focusing mostly on the catheter-based ASD closure, not surgical-based ASD closure, because I think that should be covered by somebody who has more expertise in the surgical area. So as we all know, ASD constitutes about 6 congenital heart defects. It affects females 2 to 3 times more commonly than males, and ostium secundum ASD is the most common type of ASD. And it results from deficiency of, sorry about that. So we're going to discuss the anatomy, physiology, then indications and complications associated with transcatheter closures. And ASD constitute about 6 to 10% of all congenital heart defects. It affects females 2 to 3 times more commonly than males, and it results from deficiency, perforation, or absence of floor of fossa alveolus, which is derived from primary embryonic septum. So as you probably have learned before, there are 4 types of ASDs. The most common is the sinus venosus ASD, which is the deficiency in the floor of fossa alveolus, and about 75% of all ASDs are secundum ASDs. And then you have sinus venosus defects, which could be of 2 different types depending on their location. They could be SVC type of sinus venosus ASDs and IVC type of sinus venosus ASDs, which is less common than primary atrial septal defects, which is the second most common atrial septal defects. And usually, primary ASDs are associated with things like common AV canal, more common in children with Down syndrome. And a very rare type of ASD is a coronary sinus type of defect, where there is deficiency in the roof of coronary sinus, thus creating an ASD. And then this is a cadaveric specimen, which, as you can see here, this is the superior vena cava, inferior vena cava, and this is the floor of fossa alveolus. As you can see, there's a probe which goes through the PFO, and usually this floor is deficient in ASDs or the secondum ASDs. As far as physiology is concerned, ASD usually would cause left to right shunts with step up in saturations from SVC to the right atrium or right ventricle. We typically in our lab do not take saturations in RA or RV if we do not suspect any ventricular level shunt. We just do saturations in SVC with, and as you can see, there's a step up of about 12% from 73 to 85% in pulmonary arteries. And this patient had QPQS of 2:1. And usually this would cause right heart enlargement and over a period of time, if left untreated, usually in second or third decade would cause increase in RV pressure as well as pulmonary artery pressure, thus leading to pulmonary hypertension. So usually the therapy of ASD is either percutaneous closure or surgical closure. Percutaneous closure is usually recommended only for secondary ASDs. It is a sort of contraindication for other ASDs. There have been few um, case reports where there were attempts to close the sinus venosus, superior sinus venosus ASDs using a device with combination of covered stents, but that is not a standard of care. Um, the uh, the other requirements for percutaneous closure of ASDs would be adequate superior and inferior rim around the ASDs, and there should be no right to left shunting. A right to left shunting would be a relative contraindication for ASD closure, but there are some instances of right to left shunting where we have performed ASD closure um, to promote right ventricular growth. Surgical closure usually has a very good prognosis, especially if it's done under 25 years of age with PA pressures of less than 40. And if it is done in older patients or when the pulmonary artery pressures are increased to more than 40, there is decreased survival due to stroke and risk of atrial fibrillation and heart failure. So surgical closure of ASD is usually done under direct vision, either with a patch closure or direct suture closure. This is how a patch closure looks like. The patch could be pericardium, Gore-Tex, Dacron, depending on surgeon preferences. And usually, as we said, sinus venosus type of ASDs or IVs or primum ASDs or coronary sinus defects, they're all closed surgically. There is currently no approved devices or stents available for closure of ASDs besides secondary ASD. So surgical closure is usually done via median sternotomy. There have been a lot of other developments where a partial or mini sternotomy is done or lateral thoracotomy is done. There have been some reports of video-assisted thoracoscopic ASD closures being done. Traditional ASD closures, surgical ASD closures have very low mortality rate. They do have some risk of arrhythmia, especially if done in older age. And besides usual surgical complications like pneumothorax and pleural effusions, it is a very safe safe procedure. There are several studies showing higher incidence of pericardial effusion post-surgical ASD closure, which is called as post-pericardial syndrome or Dressler syndrome, which has not been reported after transcatheter ASD closure. Long-term results after surgical closures are very good with very low mortality rates. Percutaneous closures has been increased over time since early 2000s due to availability of the devices. And the mortality rate for percutaneous ASD closure has also been very, very low. In fact, the mortality rates for surgical closure of ASDs are similar to the transcatheter closure, even when you account for erosion-related mortalities. This was a very good study done from Children's Hospital of Philadelphia. This is the study which says that if you look at this graph, it says that if you come in 2007 to a hospital in USA, your chances of getting a percutaneous closure was much higher, but as you see this graph our chances of getting surgical closure was much less, and this kept dwindling down till 2012. And in recent years, there has been again slight increase in surgical closure of ASDs, and that was mainly because of the reported incidence of erosions with the Amplatzer devices in recent years, where there were significant concerns for erosion, especially with large devices and large holes. And at least in USA, the cardiologists were more cautious and were avoiding device closures in large ASDs, and they were being referred to surgery. But this could very well change again, and with the availability of other new devices with very low erosion risk. So percutaneous ASD closure was first described in 1976 by Dr. Mills and Kings, and initially it has very low complication rate. The procedure time was very short, hospital stay was very short, and this had led to significant advancements since then in the device design and the procedure technique. And also this device itself has also led to significant innovations in other devices and stents for pediatric use, which has helped in things like PDA closures and BSD closures. At this time, more than 80% of ASDs are closed in catheterization laboratories. More than 80% of isolated secondum ASDs are closed in catheterization laboratories. There are very few ASDs which are about 20% are still closed surgically, which are mainly because of the technical reason or patient preference. So indications for ASD closure, the class 1 indications are hemodynamically significant ASD with suitable, these are indications for transcatheter ASD closure. So hemodynamically significant ASD with suitable anatomical features, which include adequate rims, and we'll talk about how to assess the rims around ASD for suitability of device placement. ASD closure is also indicated in right to left shunt who has sequelae of paradoxical emboli, such as stroke. And this is mainly derived from adult data with the RESPECT trial, and which had showed significant less incidence of stroke post PFO closures in patients who have had cryptogenic stroke. There is also class 1 indication, which means there is a consensus agreement that ASD closure should be done in patients who have right to left shunt and cyanosis and who do not require such shunts to maintain cardiac output. Some of the examples would be patients who have abstinence anomaly and they have a PFO which is causing cyanosis. And if you close the PFO or close the PFO in cath lab and you do not find any decrease in cardiac output, that would be a reason to close ASDs. In a lot of children, we have closed ASDs with right to left shunt who have had pulmonary atresia and intact ventricular septum. And after perforation of the pulmonary valve, the right ventricle has not grown significantly. And in such patients, we do close the ASD to promote more flow through the right ventricle and thereby promote right ventricular growth. So that would be another indication for closing the ASD, besides just left to right shunt. And then if you have a small secondum ASD and there is risk of paradoxical emboli with chronic indwelling catheters, pacing leads, or patient has hypercoagulable states, then in those patients also ASD closure is indicated, even if the ASD is small and even if the ASD is left to right with small shunt. If patient has a severe pulmonary hypertension or irreversible pulmonary vascular disease, that's a contraindication for ASD closure because these patients are dependent on ASD to maintain their cardiac output due to high RV or pulmonary artery pressures. Ideal age for closure is about 2 to 4 years. In sinus venosus defects, it could be delayed for 4 to 5 years. and that is due to the fact that you need more tissue to mobilize if you have to do water procedure, and again the baffle obstruction rates are much less if done in older children. If the patient is symptomatic even in infancy, which could happen in about 8 to 10% of cases, there are patients who could develop early pulmonary vascular disease or congestive heart failure. These are called as malignant ASDs. In those patients, early closure is recommended after you rule out other associated lesions. Usually, if the ASD closure is done in infancy, it is a surgical closure, but the ASD closure can be done in cath lab in children as small as 5 or 6 kilos, and we have done. I personally have done a 5-kilo child who had pulmonary hypertension and a Down syndrome child with significant high QPQS. So it could be done in smaller children also, depending on how big is the ASDs and how much tissue is around or how much rims are there around the ASD. But in general, in small children, a surgical closure is preferable. If the patient presents beyond 4 to 5 years of age, it can be closed any time after that, irrespective of the age. If patient had a symptomatic sequel of paradoxical emboli such as stroke, then this also is an indication for ASD closure. And these are all, there was a recently published Indian guideline about all congenital heart defects treatment. And the reference is down there if you want to look up that paper. So usually the pre-procedure evaluation starts with physical examination. You want to know about the associated syndrome, including Down syndrome and other syndrome which could affect airway assessment. Small children almost always require general anesthesia for the procedure. Older patients may be okay with sedation, but if you plan to do a transesophageal echocardiogram during the ASD closure, then you would need general anesthesia. There are a lot of centers, especially outside USA, even in USA, who would do ASD closure using transthoracic echocardiography, which is perfectly acceptable. In those patients, a general anesthesia might not be required. And EKG and chest X-ray should be done prior to any surgical or catheterization procedure. And as we talked about echocardiogram, you have to have a TE or capability of doing transthoracic echocardiogram yourself during the procedure. Well, I would say one more thing. There is also possibility of doing intracardiac echocardiogram. Besides TEE or TEE, that would require a second sheath to be placed in the vein. It usually is an 8 French or 9 French sheath to be placed in the other femoral vein, and you can do echocardiogram yourself. So EKG usually shows right axis deviation with right bundle branch block. You can also see RA dilation. I would not say that there is RA dilation on this particular EKG, but there is a right bundle branch block and right axis deviation. So when we go to cath lab to assess the rims for ASDs, these are the rims we would be looking for. You would be looking for SVC rim, the posterior rim, IVC rim, AV valve rim, aortic rim, and right upper pulmonary vein rim. So if you think of echocardiogram, usually the apical four-chamber view would give you an estimate of the AV valve rim and the posterior rim. And the bicable view on the transthoracic or transesophageal echocardiogram will give you an estimate of the SVC rim and IVC rim. The parasternal short axis view, which is through the aorta, will tell you about the retroaortic rim and also the posterior inferior rim. And the right upper pulmonary vein rim you can get from the subcostal short axis or sagittal view, and this also can be obtained during TEE when you rotate the probe to 30 degrees. So these are all the rims which should be carefully assessed. At this time, I would say absence of the posterior inferior rim or IVC rim is an absolute contraindication for ASD closure, because the device embolization rates are very high when you have deficient IVC rim or deficient posterior inferior rim. In general, it is recommended that there should be a rim of at least 7 millimeter around the ASDs. But with the Gore devices, we have closed ASDs with even deficient retroaortic rims with absolutely no retroaortic rim, and even then the device closure is possible. Even with Amplatzer, with having some deficient rim, device closure is possible with some deficient retroaortic rim. However, with the more recent talk of erosions, a deficient retroaortic rim is a risk factor for erosion with the Amplatzer devices. As we talked about, you have to have three standard views: the short axis view, four-chamber view, and bicable view. And then during TE, when you do short axis view, you can evaluate for the retroaortic rim and the posterior rim. So this is the apical four-chamber view. As you can see here, there is this patient particularly has a good AV valve rim. There seems to be a good posterior rim also. So this would be the right upper pulmonary vein rim, and this is the AV septal rim. And this patient has good rims all over. So this patient was a good candidate for device closure of the ASD. So in USA, there are only two FDA-approved devices which are used for ASD closures. One is the Amplatzer septal occluder, which was initially made by Amplatzer company, which was bought by St. Jude and then eventually bought by Abbott. And then the Gore Cardioform septal occluder. There has been three versions of these devices. The first version was Helix devices, which is not available anymore. The second version was Cardioform septal occluder, and the latest version is Cardioform ASD occluder, which is most commonly used now. But both Cardioform septal occluder and ASD occluder is available in USA. I'm not sure if it's available outside USA. But there are several other devices besides these two which are available outside USA, in Europe and in India, and in Asia. The Occlutech devices, which comes from anywhere from 4 to 40 millimeters. There's Cocoon devices. There's Seraflex ASD occluder. These are all some versions of the Amplatzer devices with the frame looking pretty much similar. They differ in their delivery system. The Amplatzer devices has a very stiff delivery system versus a lot of these devices have very flexible delivery systems, so you would know how the device would look like once you release it. Once you deploy it versus the Amplatzer device, you probably won't know till you release how the device would look like. There has been a lot of research into biodegradable devices. None has been commercially available yet. There are partially biodegradable devices such as BioStar Occluder, in which there is a plastic frame over which a biodegradable material is mounted. over a period of time, the biodegradable material resolves, leaving a plastic frame behind. So that's why it's partially degradable. There are fully degradable occluders which are under research, where the material completely resorbs uh, inside the tissue in a year or so, and there's nothing left besides the endothelium which covered this device. So they are exciting prospect, but there has been some concerns of fragmentation of the material causing stroke, uh, and they have not been um, completely in clinical use yet. They're still under research phase. So septal occluder was the first device which was approved by FDA. It has excellent long-term and mid-term outcomes. It is a nitinol frame with with a polymer fiber cover inside, which promotes clotting within the device. It is a self-centering device, which means the waist of the device sits inside the ASD, and the left atrial disc is 6 to 8 millimeter larger than the waist of the device, depending on the size of the device, and the right atrial disc is 4 to 5 millimeter larger than the waist. As the size of the device increases, the wire thickness increases, and usually happens at 11, 18, 26, and 32 millimeters. Um, and the device size is chosen based on the waist of the device, not the total size of the device. And usually the device size is very close to the diameter of the defect as possible. And usually we use top flow diameter technique to measure the size of the ASD. The other, as we talked about, is the Gore Cardioform septal occluder, which is a wire frame covered with a thin PTFE membrane. The delivery system is about 75 millimeter catheter, and it goes through a 10-French sheath. It is available in 15, 20, 25, and 30 millimeter sizes. This is not a self-centering device, which means there is a central waist which is fixed diameter. The device size is about 30. It can be from 15 to 30 millimeters. And once you put the device in, the device actually moves inside the septum, and depending on where it moves, there is some chances of that there might be residual shunt after the ASD closure. And there is a small animation which shows how the device is deployed, and then you would understand why this is not a self-centering device. So if you look at this, this is how it is delivered. This is the left atrial disc coming out. And as you can see, in center, there is no waist. It's basically a 3-4 millimeter central waist, and the disc on both sides are equal. And once the device is released, if there is a 15 millimeter hole, this device can move anywhere along the 15 millimeter and would sit anteriorly, posteriorly, superiorly, inferiorly, anywhere along that hole. So that's why this device was replaced by a newer type of device which has a self-centering waist. So this is the newer device, which is Cardioform ASD occluder, which has a large diameter central waist, and it also comes in much larger diameter to close larger holes. Previously, the other device was available only up to 30 millimeters, which could close only holes up to 17 or 18 millimeters. And it has similar efficacy and privacy safety as other devices. It was recently approved in August after completing initial enrollment. This is how this device looks like. So that's the delivery catheter. which can go with or without the wire. That's the left atrial disc which comes out. And as you can see, the central waist is much bigger, which would be basically. And then the right atrial disc comes out, which is released. And once the device is released, it does not move within the septum. It would stay in its place. So that's why it is a self-centering device, just like the Amplatzer device. So the procedure itself, depending on what is available in your lab, trans-esophageal echocardiogram, TTE, or ICE, either of those is essential for this procedure. We just use some cath lab just use venous access. We also do arterial access for pressure monitoring, although it is not absolutely necessary. And then you do right heart cath to assess pulmonary vascular resistance and KPQS. And then the balloon sizing is the next part. So once you cross the ASD, put the wire in the left upper pulmonary vein and left lower pulmonary vein, you pass sizing balloon. You inflate the balloon till there is obliteration of shunt by echocardiography, and then you deflate the balloon very slightly till the shunt reappears, or barely there is shunt, and then you reinflate again very slightly to completely get rid of the shunt. And at that point, you measure the waist of the balloon by echocardiography as well as the fluoroscopy. And usually there is only about 1 to 2 millimeter discrepancy between the echocardiography measurements and fluoroscopy measurements. And based on whatever your soft floor size is, we choose the size of the device. If you were using Amplatzer, specifically in this patient, you probably go with a 14 millimeter or 13 millimeter, maybe a 14 millimeter Amplatzer. If you would use a same thing with the Occluder device, that also depends on the waist of the device rather than the whole size of the device. Versus the Cardioform device, it varies from the size of the hole. For an 8 to 15 millimeter hole, you would use probably a 32 millimeter Cardioform occluder. This is how a Cardioform septal occluder is deployed. This is the lateral view. As you can see, there are these two discs, and they should be separated. When we deploy these, you should see separation between these two discs on both anterior end and posterior end. This is where the SVC would be caught, and this is where the IVC would be caught. The device looks almost horizontal because of the tension from the delivery cable. Once you unlock the device reorients clockwise in this direction and would be more vertical than what it is right now. And as you can see, there is a TE probe to help assist in placement of the device. This is how it looks like after the closure. This is a Amplatzer device, and this is a Gore device. So contraindications for transcatheter ASD closure would be if you cannot take anticoagulation medications such as aspirin or warfarin, because the current recommendation is to have patients on aspirin or Plavix at least for 6 to 12 months after the ASD closure because of the concerns for TIA or stroke. Other contraindication would be if the device is large enough, it would interfere with other structures or cardiac valves or pulmonary veins. If there is active endocarditis or there is no intracardiac thrombi. The complications include minor complications such as transient benign arrhythmias or air embolism, which a lot of times does not have significant effect. Stroke or malignant arrhythmias are rare. There have been reports of complete heart block, which are transient after ASD closure, specifically in small children. Usually they disappear, they resolve in 1 to 3 days after procedure, Occasionally, the device has to be removed surgically or by catheter if the heart block doesn't resolve. We have had patients who, and in older patients, there has been about 5% incidence of new onset atrial fibrillation, especially if the device closure or ASD closure is performed after 40 years of age. In younger patients, the reports of atrial fibrillations or atrial arrhythmias are very, very low or barely reported. I personally had one patient who had atrial fibrillation less than 18 years of age after ASD closure. Pulmonary vein perforation, there has been only one case reported. Device embolization is probably the most common major complication associated with transcatheter ASD closure. And then erosion, although it is talked about a lot, but the incidence is about 0.3%. So there was a big paper which came out from the Amplatzer trial, about 1,000 patients. And all of these patients' age varied from 3 months to 83 years. The erosion rate was 0.3% in this retrospective study. So 3 out of 1,000 patients had reported erosion. The management of complication, if the device embolizes, you have to do anticoagulation, and you can attempt retrieval in the cath lab. If that is not possible, which could be because the device is in the left ventricle, and attempting to retrieve device from left ventricle could lead to injury to mitral valve. In those situations, surgical consultation is probably the best way to retrieve the device and probably close the surgery at the same time. If device erosion were to happen, usually it is recognized by patients complaining of chest pain or shortness of breath. You would need to do emergency echocardiography followed by fusion and surgical consultation with removal of the device and closure of the erosion and closure of the ASD at the same time. Occasionally, you can have thrombus formation around the device, in which case anticoagulation is probably the best way to treat it. Acute mitral regurgitation is again very, very low. Usually that is because of the device, which is large, impinging on the anterior leaflet of the mitral valve. In those cases, again, we have to take the device out and use a smaller device, or probably have surgical closure of the ASD if the smaller device is not stable. If you have heart block, if it is transient, sometimes using steroids for 24 to 48 hours can help. If the heart block is not transient, it is persistent after 1 or 2 days, then either device removal with surgical closure or pacemaker replacement would be another option if the patient would not is a poor candidate for surgery. Brief mention about PFO closure for stroke. The incidence of PFO closure in young adults is from 15 to 35%, and this is usually due to right collection across the PFO. The reduce and close trials have shown significant benefit of transcatheter closure over medical therapy. Both Amplatzer PFO Occluder and the Gore Cardioform devices are approved by USA FDA for PFO closure. Occluder has its own PFO Occluder, which is available outside USA for secondary prophylaxis of stroke. When we close ASDs in adults, there is a little caution which should be practiced. A lot of times these adults would have left ventricular diastolic dysfunction. So it is very important to assess the left ventricular function prior to ASD closure. If you are attempting ASD closure, whether surgically or catheter-based approach, it is important to know what is the LV and diastolic pressure prior to ASD closure. If the end-diastolic pressure or LA pressure is more than 18, then the patient should be treated with heart failure medications first before attempting for ASD closure, because this could lead to acute pulmonary edema after the ASD closure. There could be other options. You could use a fenestrated device. I think Occluder has a fenestrated device for such purposes. Um, or the best option would be to treat with heart failure therapy for 3 to 6 months prior to attempting for ASD closure. There are some other techniques which are available. Again, they are not widely used clinically to close the ASD without actually using the device and without surgery. There was a RFX closure system which uses the RF energy to stick the flaps of PFO. There was a trial in Germany. I think the results were not very good. About 45% of patients continue to have shunts after 6 months. But if the PFO was smaller, the closure rate was very high. But it is much less than a device closure. So this did not get much traction besides the trial. There is another system available which is called as Novel Stitch, which is made by a company called as Heart Stitch. Again, this is not FDA approved, but it is CE marked, which means it is available in Europe. This works by passing 2 sutures via transcatheter approach across the flap of PFO and then tightening these sutures, thereby closing the PFO. Again, these are not, this is not something where you can close the ASD with, but this could be some technique which could be used in the future to possibly put a patch by a transcatheter approach, in patients with ASD. The initial trial with 192 patients showed at follow-up 75% had no shunt, but 11% had significant shunt. So again, this would not be an ideal option for ASD closure, but could be considered for PFO closure. So I think that's all I have for the ASD closure. If anybody has questions, I'm happy to answer them.